Alright guys, this is chapter 36, multi-system trauma and trauma in special patient populations. Alright, we're going to go over the education standards, chapter objectives, key terms. We're going to do talk about multi-system trauma in the special patient populations, and the assessment-based approach. Alright, our case study. Excited to hear the approach of the ice cream truck in his neighborhood, 7-year-old Russ runs to the street to look for it. He fails to see the car approaching from the opposite direction until it's too late. Turning towards it at the last second, the bumper strikes Russ in the torso, causing his head to impact the hood before throwing him down to the ground as the driver screeches the car to a halt. All right. How will Russ's age affect the type and distribution of his injuries? All right. Remember, we talked about when adults strike a car versus when a kid strikes a car. Kids, it's usually the chest and head. Adults, it's the pelvis and lower extremities. All right. How might Russ's injuries present differently from the same injuries as an adult patient? And what differences are required in assessment and management of this patient as compared to as an adult? All right. The involvement of multiple body systems in trauma makes management of the trauma patient more challenging. There are special considerations in assessment and management of pediatric, geriatric, pregnant, and cognitively impaired trauma patients. All right. So what exactly is a multi-systems trauma? A multi-system trauma patient is considered to have multi-system trauma when more than one major system is involved. Significant forces increase the risk for injuries to multiple systems. Morbidity and mortality are higher in patients with multi-system trauma, and the risk of developing shock is higher with multi-system trauma. All right. The care for multi-system trauma depends on these systems involved, but the definitive care, just like with any trauma, is surgery. All right. Golden principles of pre-hospital multi-system trauma care. Your personal safety is most important and should be maintained when you arrive on the scene and throughout your patient care. After arriving on the scene, determine whether you need additional resources. Because multi-system trauma can result from various causes, the additional resources required may vary. Knowing the mechanism of injury can help the EMT anticipate what injuries the patient may have. Multi-system trauma can result from blunt trauma, penetrating trauma, MVCs, blast injuries, deceleration injuries, or any other type or combination or mechanism. Airway ventilation and oxygenation are the keys for successful management of a multi-system trauma patient. Each multi-system trauma patient should be assessed and that patient's specific emergency care needs identified. Because multi-system trauma patients may suffer from a spinal injury, you want to always consider spine motion restriction. Inspect for possible airway obstruction and apply suction as necessary. Open the airway using the jaw thrust maneuver. Determine whether your patient is breathing adequately based on the rate and tidal volume. If ventilation is inadequate, provide positive pressure ventilation. Administer high concentration of oxygen as needed in the multi-system trauma patient to saturate the hemoglobin with as much oxygen as possible and to attempt to maintain delivery of oxygen to the cells. All right. Multi-system trauma patients can be found sitting, standing, prone, or supine when you arrive on scene. These patients may require spine motion restriction. Any musculoskeletal injury should be splinted en route if the patient is unstable. All right, cellular oxygenation is impaired when a patient is bleeding profusely. The loss of hemoglobin reduces the capacity of the blood to carry and deliver oxygen to the cells. This leads to cellular hypoxia and anaerobic metabolism. All right. After treating immediate life threats, perform a rapid secondary assessment to identify any additional injuries that could potentially be life-threatening. Rapid extrication, rapid transport of the critically injured multi-system trauma patient are essential. The on-scene time is critical and should not be prolonged. The on-scene time is considered part of the platinum 10 minutes and the golden period, which injury and definitive care at the hospital, a time span that should not be exceeded and should be minimized if at all possible. All right, remember these trauma patients, we do not want to stay on scene with them more than 10 minutes. All right, injury to a pregnant uterus can result in severe bleeding. These changes can make the injured pregnant patient more susceptible to shock. However, because of the increased plasma volume in pregnancy, the signs of shock can be masked and delayed. All right, the pregnant woman's renal blood flow is also increased. Their pelvic joints are loosened and their center of gravity changes, both of which can make them prone to accidents and falls. Pregnancy has also been shown to be a time when domestic abuse is more likely to occur. Trauma to a pregnant woman, whether severe or minor, can have significant effects on the health of the fetus. If there is any complaint of abdominal pain or contractions, you must assess for crowning and any kind of vaginal bleeding. The unbelted pregnant crash victim is twice as likely to have vaginal bleeding or to give birth, and fetal death is 3 to 4 times more likely. Shock is a frequent cause of death to both the fetus and the mother. It is estimated that 41% of fetuses die when the mother suffers a life-threatening injury. A traumatic maternal cardiac arrest poses a significant risk to the fetus. Although the chance of the fetus surviving the maternal cardiac arrest is poor, it is possible, especially with high-quality CPR. You should anticipate vomiting and have suction readily available, especially in a supine patient. Assess if the patient is breathing adequately and if bilateral breath sounds are present. Assess the patient's ventilation if the tidal volume or respiratory rate is inadequate. Administer high concentration of oxygen by non-rebreather mask if breathing is adequate, or you can bag your patient if breathing is inadequate. The vasoconstriction response in hypovolemia or shock will reduce blood flow to the uterus. The fetus is vulnerable to any reduction in oxygen and can become severely hypoxic before the pregnant patient shows signs of hypoxia. Perform a visual exam of the vaginal opening to assess for crowning and or bleeding. Remember that you have 2 patients. If labor occurs because of the trauma, you may need additional resources to help you manage both the mother and the newborn. The best method to care for a fetus is by anticipating injuries and shock and aggressively managing the mother, okay? Some findings may prompt you to suspect abuse, all right? These are going to include bruises or burns in unusual shapes or locations, an injury that doesn't seem to correlate with the cause provided or the developmental stage of the patient, more injuries than usual for a child of that same age, multiple injuries in various healing stages, and a delay in seeking emergency care. An improperly placed lap belt across the abdomen can lead to compression fractures of the thoraconombular vertebrae in a rapid deceleration motor vehicle crash in pediatric patients. The high displacement of the rib cage and the internal organ placement makes them more susceptible to injuries to the spleen and the liver. Greater chest wall flexibility can allow for internal injuries with few, if any, external signs of trauma. Children also have a higher metabolic rate, which requires a greater amount of oxygen and glucose to be consistently delivered to their cells. Traumatic forces are more widely distributed in a pediatric patient than in trauma, and this makes them more prone to suffering from multisystem trauma. Both the PAT and PALS assessment collect the same information and general impression of the pediatric patient. The appearance or consciousness component refers to the assessing of the child's overall mental status. Are they unresponsive, irritable, alert, their body position, and their muscle tone? The breathing component relates to the work of breathing as determined by a visual assessment of their effort of breathing, absence of breathing, or decreased respiratory effort. plus any audible sounds associated with the patient's respiration. The circulation or color component is assessed by observing the patient's skin color, cyanosis, and pallor. The brachial pulse should be assessed in an infant less than 1 year of age. Because the myocardium is immature, the pediatric patient's ability to increase cardiac output depends primarily on raising the heart rate. Therefore, tachycardia is the earliest and most sensitive sign of hemorrhagic shock in pediatric patients. Assess the breathing rate and tidal volume. Keep in mind that what is considered a normal respiratory rate and tidal volume are age and weight dependent. You need to look at both the chest and the abdomen when making this determination. Carefully provide ventilations if either the rate or the tidal volume is inadequate or if bradycardia is present. Pediatric trauma patients can fatigue very quickly. Administer supplemental oxygen and maintain an SpO2 of 95% or greater. I know I've said this several times, and you probably, some of you remember me hearing this, okay? Kids, pediatric patients, they can compensate. They compensate very well until they can't, okay? They will go, and then automatically they just stop, all right? So you have to pay very, very close attention to them. Most of the management for pediatric trauma patients is the same as for an adult. Most injuries associated with falls is fractures. Motor vehicle collisions are the second most common cause of trauma in the elderly. Older drivers are more likely to be killed or injured in these accidents than younger drivers. Geriatric patients are more susceptible to injuries than other adults, even in cases of minor trauma. Minor chest trauma can cause lung injury. Decreased muscle size in the abdomen can mask abdominal injuries in the elderly. Thinner skin in the elderly results in more easily infected soft tissue injuries. Chest wall injuries can quickly lead to respiratory failure in the geriatric population. You should monitor the elderly trauma patient's oxygenation using a pulse oximetry. Elderly patients who are hypertensive prior to an injury may have normal blood pressure readings when they are in shock. Prevent hypothermia and splint fractures. Remember that traction splints are not used to treat hip fractures. Provide rapid transport to the closest appropriate facility. All right. Cognitively impaired patients are more prone to trauma. Conditions include dementia, autism, brain injury, stroke, Alzheimer's, and Down syndrome. And it can affect assessment and management. All right. It can be difficult to recognize patients with cognitive impairments when you begin your assessment. Some of these patients have no physical signs of their mental condition. Some patients with dementia experience cardiovascular changes that make them prone to injury. Other patients have a loss in musculoskeletal strength due to aging or impairment that can lead to falls or other injuries. Memory loss from Alzheimer's or other cognitive impairment can also alter the patient assessment. All right. They may not know where they are, what year it is. This is normal for them, y'all. So make sure you get a good history from any kind of bystanders or family members that are there. All right. The psychological implications of trauma can be different in this population. Many of these patients do not know what is happening even before the trauma occurs. They may be confused or upset. The traumatic event can make it more difficult for them to communicate and cooperate with you. The trauma assessment provides the most pertinent information about your patient because many of these patients are not able to tell you what's wrong. It is important that you constantly reevaluate them. Cognitively impaired trauma patients need special care. All right. Always err on the side of caution and treat as if the patient has a head injury. Unresponsive or altered mental status, especially in trauma patients, should always suggest the possibility of head injury. Never assume that mental status changes in a trauma patient are due to drug or alcohol intoxication or previous medical conditions. However, caregivers can give insight into the patient's baseline and mental status. Assess your patient's mental status using the AVPU mnemonic. A stands for alert, V stands for verbal, P stands for painful, and the U stands for unresponsive. Utilize tools such as the GCS and the Pediatric Assessment Triangle to provide additional information about the patient's mental status. This will provide a baseline for your reassessment down the line. Any pregnant patient in their 20th week of gestation or greater who has any trauma, even minor, should receive high-flow O2 regardless of the pulse ox reading. Although the pregnant patient may not have any signs or symptoms of hypoxia, the reduction in blood flow to the uterus during compensated shock can cause the fetus to become severely hypoxic. All right. So, we need to know the normal vital signs based on your patient's age. All right. You need to know their history. Are they pregnant? If so, how far along? Any vaginal bleeding? Have you been feeling the baby move after the trauma? All right. How old is the patient exactly? Do they take any medicine? Are they allergic to anything? What's their medical history? Are they supposed to take medicines that they don't take? All right. Patients, especially children, those with cognitive impairments or those with an altered mental status, may not be able to provide you with the information that you need. Special trauma patients may not respond to injury the same way that other trauma patients would. Document signs and symptoms accurately, okay? And as always, we're going to use our standard precautions, BSI, scene safe, establish and maintain inline stabilization. For third trimester pregnancy, we want to tilt the backboard to the left. Why is this? Because in that third trimester, the baby is big enough to impede blood flow to the vena cava, all right? So we tilt them on their left side. For children younger than 8, pad from the shoulders to the hips. For the elderly, you need to pad the boys between the back. Any patient who deteriorates must be transported immediately. Remember, bradycardia in a pediatric patient always requires ventilation. Most of your pediatric patients are that's going to be their first sign and symptom of things going wrong is bradycardia, okay? And if we can get their ventilations under control and amped up, we can increase their heart rate, all right? Maintain a patent airway and adequate breathing. Use the jaw thrust maneuver for all your trauma patients. Be prepared to suction, administer oxygen, and monitor the airway, breathing, pulse, and mental status. If major bleeding to an extremity is not stopped with direct pressure, apply a tourniquet. Notify the receiving facility specifically what type of trauma patient you are bringing to them. Consider the use of ALS or air transport for these patients, and always follow your local protocols. All right. We want to give the facility a good amount of time to get their things in place. All right. As much time as you can give them, the better off that patient's going to be, all right? And we want to reassess our vital signs every 5 minutes. The EMTs arrive, and as they approach to apply inline stabilization to the spine and open the airway, they note a pale patient who appears unresponsive and who has labored breathing. One EMT uses a jaw thrust maneuver to open the airway as another completes the primary assessment. The EMTs insert an OPA and begin assisting ventilations and administering supplemental oxygen. Russ has several superficial abrasions and minor lacerations, but no external bleeding. The EMTs perform a rapid secondary assessment and provide spine motion restriction. Padding from the shoulders to the hips to maintain the neck in a neutral alignment. The EMTs are transporting within 6 minutes of arriving and immediately notify the receiving facility. En route, they continue management of the airway and breathing and keep Russ warm, as well as obtaining baseline vitals. Russ is stabilized at a level 3 trauma center and then flown to a children's hospital for further management. Uh-oh. I'm a little ahead of myself. All right, although he faces months of rehab, the quick action of the EMTs provided him with the best opportunity for a full recovery. They were on scene, had him stabilized, or on a backboard, ready to transport within 6 minutes. That's pretty freaking good, y'all. So, use the golden principles of trauma. We do not want to be on scene for a long time with these patients. We want to do the ABCs first: airway, breathing, circulation, treat for shock, control any external bleeding, any arterial bleeding, gross bleeding, and get on the road. All right, there's not a whole lot we can do for these people except get them to the appropriate facility. Okay. All right, guys, so this is your last trauma chapter. All right, I'm gonna get it uploaded here shortly. Thanks.